Hi there, my name is Chris Bashi. I'm the Medical Director of the Mehlville Fire Protection District, and today we're going to talk about Mehlville's Pit Crew CPR model. We have decided to coordinate the way we approach cardiac arrests in this district, mostly to minimize compression interruptions. And the reason that we want to do that is because if you look at coronary perfusion pressure, it decreases very quickly, as you see in the graph there, with interruptions in chest compressions. And it takes several minutes of chest compressions to build up an adequate coronary perfusion pressure when we resume CPR. So for us, it may seem like we've only stopped CPR for just a few seconds, but in reality, the coronary perfusion pressure takes a while to build back up again. So how can we stop interruptions in CPR? We have to look at when we have classically had interruptions in chest compressions, and the first one was airway interventions. I think everybody, if you've been doing this a while, has been in a situation where we've stopped CPR to place an airway, and we're not going to do that anymore. IV access is another one. Frequently you have to stop chest compressions to gain access to the patient's upper extremities to place an IV. But with the advent of the EZ-IO intraosseous device, we have pretty decent access to the lower extremities, usually without stopping chest compressions. So we are not going to stop chest compressions for IV access. Now we have to stop chest compressions for pulse checks. We obviously have to stop for a rhythm analysis. We have to stop to defibrillate the patient. And we have to stop to change compressors. But what we're going to do with this pit crew model is organize that dance so that we can do all four of those events within a 10-second period of time, so we don't have to stop CPR any more than 10 seconds in a 2-minute cycle. Now, patient movement is another time where we have ineffective CPR usually, but we are going to work most of these codes where they fall on the scene without moving them, so we don't have to stop interruption or perform poor CPR to move the patient. So let's talk a little bit about our pit crew model. As I said, it choreographs tasks to minimize interruptions. It allows us to focus on what's most beneficial for patient survival. And that may be a little bit different than what we focused on in the past. Obviously, a lot of us were taught that things go ABC, airway being the priority, but now we know that it's more CAB, where compressions are more important than the airway or the breathing. This is being used successfully by EMS agencies across the country. To incorporate a pit crew model into your agency, the model must be very specific to fit your agency, taking into account the equipment that you use and the level of training of the personnel that you bring to the scene, as well as the number of personnel that you may have on the scene. We've tailored this model to be specific for the Mehlville Fire Protection District. We've been using it since 2014, and we've had a lot of success with it. So let's talk a little bit about our goals of this program. What we'd like to focus on is high quality chest compressions. We want to limit our interruptions, as I said, to no more than 10 seconds in every 2-minute cycle of CPR. We're going to perform asynchronous controlled ventilation, so we're not going to do 15 to 2 or 30 to 2 as far as our chest compressions and ventilations. Remember that ventilations are not as necessary in the first few minutes. Most people, adults we're talking about here, that suffer a medical cardiac arrest usually have a lot of oxygen in their bloodstream that we can use to oxygenate the patient with adequate chest compressions without the need for assisted ventilation in that first few minutes. Now everything else is secondary, okay? So things like medication, IV access, we're going to get to that, but the main goal is to focus on these three things, and then everything else will be secondary. So let's look a little bit at our model. Now, our model takes into account assigned positions. We have to also take into account, does the pumper arrive first? Does the ambulance arrive first? Or does everyone get there together? Now, we're going to perform chest compressions of 100 to 120 per minute. That changed in 2015 with the new ACLS guidelines. They increased the number of compressions per minute from 100 to 120. Or somewhere in between 100 to 120. To do this, we're going to use the metronome function of our Zoll monitor. We're also going to use the CPR feedback patches that come with our Zoll monitor as well, and I'll show you how that works. We're going to do asynchronous ventilations, as I said. We're going to use either a supraglottic airway, in which case the iGel, which is what we carry, or an ET tube if you'd like to place that. But we're not going to stop CPR to place an ET tube, so it may be easier for you to place a supraglottic device. We're not mandating either device. But whichever device you use, we're going to monitor the end-tidal CO2, and we're going to use that to gauge the adequacy of the resuscitation. We're going to use our Zoll monitor or our AED off the pumper, but if we use the Zoll monitor, we're going to use it in AED mode, and I'll show you that as well. Now keep in mind, if for some reason the metronome function doesn't work on your monitor, everybody knows the song Staying Alive. If you do compressions to the beat of that song, if you can think about that in your head, that gets you about 103 compressions per minute. So that's about how fast we want to do compressions. So I'm going to show you a little video here. Here's our pumper arriving. The first rescuer is going to go inside to start CPR. Our other two rescuers on the pumper here are going to get the EMS equipment and bring that inside. But we'd like to get somebody right inside, right off the bat, to begin chest compressions if we know we're going to a cardiac arrest. And as we'll show you here, the pumper crew is pretty much responsible for those chest compressions in this pit crew model. So when the pumper crew arrives, they're going to take a triangular configuration around the patient. You'll see that we have what we call BLS and ALS positions here. We don't always have 3 paramedics on the truck. So if you look at the initial position placement here, these are the way we'd like to arrange our skill set if we do not have all paramedics. So a BLS responder is probably going to be the first person to go inside. That's our first compressor. That patient's going to immediately check for unresponsiveness, check a pulse, and begin CPR. Our BLS2 position on the other side of the patient, this is somebody that's going to have the AED. While the BLS1 compressor is doing compressions, they're going to attach the AED and prepare for the AED to fire. And then we're going to take our paramedic, in this case we'll call him him or her, the ALS1 rescuer. That person's going to take their position at the airway. They're either going to place an ET tube or a supraglottic airway. If for some reason we don't have a paramedic on the truck, that can very easily be a BLS skill to place that supraglottic airway as well, but we can't obviously place an ET tube in that situation. So let's show you a little video of what that looks like. So here's our crew arriving on the scene. First rescuer is going to immediately bare the chest, check for unresponsiveness, and begin CPR. The second rescuer on the other side of the patient is going to prepare to fire the AED, and you see our third rescuer is simulating here placing a supraglottic airway, the iGel in this case. That rescuer then is going to go ahead and give 1 breath every 6 to 8 seconds. We're going to go ahead and hook up this AED and get it ready to fire, and you see that all throughout this we have not stopped chest compressions to place the airway or to place the patches on the patient's chest, which being that we're using the mannequin here, we're going to have to simulate a little bit. But once the device is on, see him apply the patches here. It's going to turn the device on. Obviously those are simulated patches. When the AED is ready, we're going to stop CPR. We're going to quickly place the CPR puck, and then we're going to let the AED assess the patient. In this case, it will advise a shock. The patient is already cleared, a shock is delivered, and immediately after the shock, CPR resumes, and we resume bagging the patient. Now, what happens when the ambulance crew arrives? When the ambulance crew arrives, they are going to take a position on either side of the patient's legs. You see our ALS2 position there. That person is responsible for IV or IO access. We're not mandating that you place an IO because in some patients that may not be an acceptable option. But most patients, you can go ahead and just drill the leg, and we use that route to give medications. If you need to establish an IV, you can do that as well, although we have to keep in mind we are not going to stop compressions to place an IV. The ALS3 position you see there on the bottom right of your screen, that's someone we're going to call the code commander. That's our paramedic, that's probably the tech on the ambulance. He's going to take possession of the Zoll monitor and basically run the code. He's going to direct when people need to change. He's going to direct when people stop CPR. He's going to direct when we give medications. And so everything's going to run through the code commander. And again, that will be our tech on the ambulance. That way, when we resuscitate this patient, he'll have all the information needed to give a good report to the hospital. And so we'll see our ambulance crew arrive here in the video. And you see they take their position at the patient's leg. Our code commander on the bottom right hand of the screen there is going to start setting up the Zoll monitor. He's going to go ahead and take the AED patch cable from the AED monitor and throw it on over because it's compatible with our Zoll monitor. He'll turn the monitor on and prepare to defibrillate the patient if need be, and he's going to start running the code with the Zoll monitor. And you see our other rescuer there places the EZO device in the right lower extremity. Now, how do we change compressors? Okay, obviously we only want you doing 2 minutes of CPR, and so as we said, we're going to interrupt every 2 minutes with a 10-second pause to change compressors, check a pulse, and defibrillate the patient if need be. When you complete CPR, the person across from you is going to start CPR after that 10-second pause, and you are going to switch with the airway person. Okay, so every time you switch with the airway guy or girl, and across from you is the person that's going to start CPR, and we'll show you a little video of that, how that looks. So here we've got our 10-second pause coming up. We call for a change. We're going to defibrillate the patient at this point. The code commander clears the patient and shocks the patient. As soon as the patient is shocked, he says to resume CPR, and our personnel change. And you see that our former compressor changed with the airway position. And so what this means is you're going to do about 2 minutes of CPR every 6 minutes, and allows our crews to stay fresh. And so we want to make sure you stop every time we stop CPR. We want to switch up our compressors to make sure that we perform adequate chest compressions. Okay, and now I want to show you the Zoll monitor. I'm going to show you a quick little video on how to put that into AED mode. Okay, so first thing you want to do is you want to turn the monitor on. In this case, the patches are already connected to the patient. You'll see the Zoll logo pops up. The next thing that's going to happen is you're going to actually see the rhythm, but we want you to hold off until the self-check completes. The screen will light up and say passed. There it is. You see it says passed on the screen, and all you have to do is hit the analyze button. And immediately what will happen is the monitor will say stand clear, and in this case it will advise a shock. The shock button will light up. After the patient's cleared, you go ahead and push the shock button, and now it tells you to start CPR. And you see there in the white and black, we have a countdown clock. This is just showing you the CPR feedback. You'll see these white bars here that show you the depth of compressions. And again, we see our CPR time clock that will count down from 2 minutes, so that we know every 2 minutes it'll tell us to stand back, stop CPR, and we'll do a rhythm check or a pulse check on the patient. Now, what if we have extra personnel? Certainly, that's somebody we can send for equipment. That's somebody that can talk to family. But if you don't have that personnel, we want you to go ahead and use the person who is pushing medications, who's placed the EZIO, because that patient, once that EZIO is established, that person only has to give medications every 3 to 5 minutes. That may be somebody who has a few minutes to run out to the truck for some equipment. But the main message here is to bring everything that you need to run a cardiac arrest with you when you go into a cardiac arrest call. So hopefully we're not running out back and forth to the truck too much. Now, what happens when the ambulance arrives first? If the ambulance gets there first, obviously we only have 2 rescuers in this case. And so we're going to focus on chest compression. So the ALS-1 rescuer is going to go in and immediately begin CPR. The ALS-2 rescuer is going to bring the Zoll monitor in and prepare to attach it and fire it in AED mode. Once that happens, that ALS-2 rescuer will begin compressions. If the ALS-1 rescuer can do it within 2 minutes, they can go ahead and place an airway or even just place the patient on a non-rebreather mask. But we'd like these 2 rescue personnel to do a couple of rounds of CPR before moving to the airway if we feel that the airway intervention is going to interrupt chest compressions longer than 10 seconds every 2 minutes. So again, focus on chest compressions in this setting. Hopefully in our scenarios we'll get a pumper to you fairly quickly, but if not, we'd like a couple of rounds of chest compressions done before we stop anything to work on the airway. And obviously when the pumper crew arrives in this situation, we're going to slide those ambulance personnel down to their traditional positions on the patient's leg. The one will be the code commander, the other one will establish the IV or the IO access. And then the engine crew is going to take their position around the patient in the triangular configuration. And again, that's going to be our chest compression positions as well as our airway position. And we'll do CPR and compressions just like we did when the pumper crew arrives first. Every time they're done with compressions, you'll change with the airway guy, and the person across from you will start CPR. Now let's talk a little bit about how we work codes. You know, for several years now, we've done a pretty good job at this. We want to work them where they drop, okay? CPR in a moving ambulance or getting someone to the ambulance is frequently ineffective. So unless we have some kind of dangerous environment, we're going to work the patient where they drop. If the patient is in a situation where we have to move the patient for a safety reason, then move them to the closest place where we can safely do CPR and run your resuscitation there. We do not want to do CPR in a moving ambulance, as it's not effective, and we certainly don't want to scoop and run with these people like we used to. We get much better success working them where they drop. The situation comes up a lot about public places, okay? Obviously, it might be unsettling to work a cardiac arrest at, let's say, the food court at South County Mall. But again, we get the best results when we work them where they fall. So we're going to work them in public places, and we're going to do that for at least 25 minutes, longer if necessary. Don't rush the transport. As a lot of you guys know, I'm a hockey fan. Twice, to my knowledge, in the NHL in the recent years, there have been cardiac arrests on the bench in NHL hockey games, and both times the players were resuscitated on the bench. They were not moved. They were resuscitated in front of, you know, thousands of people and even a TV audience in one case. Please don't rush those folks off the scene. Let's work people where they fall, even in public places. Now, when it comes time to call the code, our current protocol is we're not leaving dead bodies in public spaces. Okay, so if we feel that we need to move the patient because we're in a public place, then we can go ahead and transport that patient. But I would only make that decision to move and transfer the patient after we feel that the resuscitation will most likely not be effective. Certainly, if we're going to transport a patient like that, we don't want to drive real erratically. We don't want to be putting anybody at risk to take that patient to the hospital, and then we can notify the ER that we're bringing in a patient that is most likely going to be unsuccessful, that we've worked at the scene for a considerable amount of time, and we would have even called the code at the scene if it were not for a public place. How do we deal with the family? Okay, most families are very receptive to us working patients where they fall. There is very little expectation anymore that we're going to scoop and run with these people to the ER. I think the main message I would tell the family is we brought the emergency department to you, okay? There is nothing that the ER can do that in a code situation that the ambulance can't do on the scene, okay? So effective CPR, medications, defibrillation, all of that is things that you have brought to the scene that we would use in the emergency department. We're not taking anybody to the cath lab that doesn't have a pulse, okay? So to establish spontaneous circulation again, you have all the tools that the emergency department has, and so we are not going to scoop and run with those folks. Keep in mind, you got to involve the family early, okay? Start talking to them, explain why we're not moving the patient, explain what we're doing. We may decide that we're going to call this code on the scene, maybe a couple of cycles before we make that decision when it looks like things aren't going real well. That's when I'd start talking to the family and saying, hey, we've done all we can do here. We'll do a few more cycles. We'll see what happens. But the longer this goes, the less likely it is to be successful. The more likely it is your loved one will have a non-survivable injury or brain damage from this whole event, and it's not going to be salvageable. So just be very direct, be very specific with these folks, but involve them early before we decide to call the code on the scene. All right, if anybody has any questions about this, please feel free to contact me. I really think that if we stick to this protocol, we'll have a lot of success with it. We've already seen a huge jump in our ROSC numbers. As most of you know, I'm very passionate about this issue. I think that this particular concept of Pit Crew CPR can work in our community. It has worked other places in the country. And again, we've seen some great numbers here. So what it takes, though, is buy-in from all of you. I need you to go out there and do this protocol, even in the middle of the night when we don't have anybody supervising it. Stay on the chest. We don't want any interruptions in those chest compressions other than that 10 seconds every 2 minutes. Run the monitor in AED mode. And really focus on compressions. I think we'll have continued success with this. Thank you very much for listening. And again, any questions, please feel free to contact me.